Kudos to you, because I got on that board and I was doing a whole lot of.
I'm not a fast person, no, I'm a bunny hill.
Oh, I was on the bunny hill. These little kids on their snowboards were like zooming past me. I ate shit for the 15th time.
My
so.
son would be one of those.
I actually started crying.
All right.
I was so frustrated. And my fiance was like, "Why are you crying?" I was like, "I don't know."
Okay, so we are going to jump into Hemopatho. So this is the other half part of the hemo. Your quiz tomorrow, 70% hemofits. Okay, so anything that from this lecture that'll be on your quiz tomorrow, either A, I'll give you a hint about, or B, it'll be super official. Okay, so I know exam brain is a thing. So, all right. So just recapping here, what is the most abundant protein in your blood? Yeah. Albumin, absolutely. And where is albumin made? Liver, absolutely. Okay, again, pay special attention to when the liver comes up. Okay. What is the most abundant blood cell?
Red blood cell?
Red blood cell. Where is it made? It is made at the bone marrow. Nice. With what hormone?
Erythropoietin.
With so bone marrow with EPO. And where does EPO come from?
Kidneys.
Nice. So this one's a little bit tricky because there's two technical places. All of your blood cells come from your bone marrow, but you need a hormone from your kidneys. Okay. And which blood cell has the shortest lifespan?
Platelets.
At how many days? No more.
10.
Blood cells that have the shortest lifespan will be the platelets at about, give or take, 10 days. And what hormone did you need to make platelets? Coming from the TPO, coming from liver. Okay, so blood cell with the shortest lifespan. Platelets, they only live for about, again, 10 days. You need TPO or thrombopoietin, that hormone, which comes from the liver. And then your clotting cascades, the intrinsic pathway triggered by. You guys just had an exam on it. How does athero end? Complicated plaque. What was exposed? The collagen at the endothelium. So your atherosclerosis that terminates in the intrinsic clotting cascade. Okay. Extrinsic then, if you damage the outer blood vessel.
It's not like clotting. No.
Clotting factors are involved, but there's.
Oh,
Oh, my childhood. What does TF mean? Tissue factor. Informally, though, if you write the fuck up in the next exam, I'll take it. That's pretty good. Okay. So just a little bit of recap there. So talking about tests for blood, a lot of different tests there. Just remember, just because someone's too high or too low, that doesn't mean that it's a bad thing, right? Take, for example, in Colorado, at altitude, do you want more or less red blood cells? More. So elevated, in this case here, makes sense. The context of altitude, that's what we desire. So again, when you guys are reading lab values, just because something's high, just because something's low, don't automatically assume that it's bad. Okay. All right, cytosis. Anybody remember this one? Condition of cells, i.e. too many. Okay. So erythrocytosis, i.e. too many red blood cells. Okay. So for an average person living an average life at sea level, would that be considered physio or patho? Patho, why?
Because you don't have an increased requirement for. Okay, well, am I on the right track?
Yeah, a little bit.
Right church wrong.
What's the issue if you have too many red blood cells?
One's too thick.
Your blood becomes too thick. Okay, so that, and again, average person, average life, pathologic. Here at elevation or in the steeps of Tibet, that'd be physiologic, right? So again, just be careful there. Leukocytosis, too many white blood cells. What would be, leukocytosis would be a physiological response to what? Infection, exactly. So an infection would cause you to increase white blood cells. But if someone has leukocytosis and they don't have a fever, is that weird?
Yes.
Why is their immune system getting ready for a battle when there's no infectious agent?
Cancer.
Could be cancer, or it could be autoimmune. Okay, so that's what I'm saying. Like, again, just because something's high, just because something's low, don't automatically assume that it's bad. Okay. Thrombocytosis, too many platelets. Okay, generally speaking, again, that is pathological. It is not beneficial to be in a hypercoagulable state. Okay. Everybody's favorite, penia. What does that mean? Erythrocytopenia, what's another name for that? Yep, what's another name for that?
Oh, anemia.
Anemia, right? So you can say erythrocytopenia or anemia. Anemia without blood. In the clinical field, you just default to red blood cells. There's something specified. Leukocytopenia, decrease in white blood cells. Immunodeficient, immunosuppressed, right? So generally speaking, for an average person living an average life, leukocytopenia, physio or patho? Patho. You agree? It's not beneficial to be immunodeficient. When would it be desirable? When would you want someone to be immunosuppressed? Maybe an autoimmune disorder? Organ transplant, absolutely. Okay. So what I'm getting with these is when you read the question, look for the context. Okay. Thrombocytopenia, lacking platelets, generally that's pretty bad. You want to be able to stop bleeding, but maybe somebody has a blood clot issue. So they're on blood thinners or something like that. Okay. All right, so what is anemia? Generally speaking, whenever you see anemia, that defaults to your red blood cells. So it means lacking your red blood cells. The most common type of anemia is iron deficiency anemia. We'll talk a little bit more about it, but most common is iron deficiency anemia. There are 4 classic, typical or early symptoms. Okay, 4 classical, typical, early symptoms of anemia. So these are just general characteristics. Pallor, dyspnea, fatigue, and weakness. Okay, those are the 4 classical symptoms of anemia. Okay, if you express any of these 4, that might be showing early signs of anemia. So why pallor? Why would somebody be pale? Exactly, your red blood cells give your skin color. Very good. Dyspnea, why would they have trouble breathing? Lack of oxygen transport, absolutely. The weird part is fatigue and weakness. Now, did you guys go over the difference in health assessment? Maybe. Okay, so fatigue versus weakness. Fatigue. This is your perception of being tired. Okay, so fatigue is the perception or being in here, just say the feeling of being tired. Weakness, on the other hand, that's physical. What can we do to assess somebody's weakness? Yeah, hand grip strength. Absolutely. Okay, so that's the difference there between fatigue and weakness. You'll see both with anemia, just understand they're not the same thing. Okay. Okay, so all of the anemias that we're about to talk about are sorted 2 ways. They're sorted by size and they're sorted by hemoglobin content. Okay, so you're gonna see everything ending in cytic and chromic. Okay. Everything ending in cytic and chromic. You can X through this subpoint right here. Okay, these are talking about the different tests to quantify size and color. You'll learn about that in MedSearch 1. Okay. So anemia, exactly as we talked about, reduced oxygen carrying capacity. Classic anemia symptoms: fatigue, weakness, dyspnea, and pallor. Didn't I have you guys write those down? Huh. Okay, so all the anemias that we covered, they usually share those four. Some anemias have unique symptoms or signature symptoms. Take, for example, spooned nails. I will never use this term. I don't even know how to pronounce this term. Okay, I will always refer to it as spooned nails. Spooned nails is going to be a signature symptom of iron deficiency anemia. So spooned nails only appears with iron deficiency anemia. We'll talk about other types of anemia, but again, this is a signature symptom. Okay.
Does that happen like right away, or does it have to like grow out?
It actually happens, I would say, within maybe a couple months of having iron deficiency anemia. So it does kind of grow out that way, but what you notice is your nails actually have a very high turnover rate. So they actually start thinning first, and then they end up spooning, again, within about like a month or two. All right, so all the anemias that we're going to be talking about today are sorted in these three categories. You're going to hear me abbreviate it: macro-normo-anemias, micro-hypoanemias, normo-normo-anemias. That's why we're talking about everything is sorted by size and color. These are your categories. Make sense? So macro-normo-anemias, what's wrong with my blood? Macro, it's large, but can I still carry oxygen? Cool. What's wrong with micro-hypo? Yeah, see, that's fun. Yeah. These are all the anemias that we're going to go through in the first part. Now, I know this looks like a lot. For these anemias, you need to know cause, if there's any signature symptoms, and if there's a treatment. Okay, a lot of these, no. I.e., there's no signature symptoms or there's no treatment for it. Okay, take for example, if it's a genetic condition, there's not really a long-term treatment there. Okay, now that's all you need to know for this. This is the one of two types. This entire quarter, I would say flashcards are fine. So if you like flashcards, now's your time to shine. Okay. So within the macro normals, you have two anemias. Within the micro hypo, you got three, so on and so forth. And we're going to roll through them. Again, it's just superficial. That's why I'm saying if you like flashcards, it'll be fine. Okay. So starting off with the macro normals. Okay, they are termed megaloblastic anemias, just means large nucleus. Because hey, they're macrocytic. Macrocytic. Okay, characterized by vitamin B12 or folate deficiencies. Because what ends up happening is you need B12 and folate for DNA synthesis. Okay, you need B12 and folate for DNA synthesis. If you are deficient in B12 or folate, what happens to your ability to make DNA? Decreases, therefore, you still have a nucleus. Remember, red blood cells shouldn't have a nucleus. Okay. And then this is, I don't know about you guys, but sometimes I blank out the title. The title tells you where we're at. So in this case, we're still in the macro norm of section. So just heads up about the titles. They tell you where we're at. Okay. So starting off with pernicious anemia. Pernicious anemia can be caused by a B12 deficiency. Caused by a B12 deficiency. So that's the cause. Well, how would you treat it then? Give them B12. Do you see what I'm saying, guys? Like the treatment's not crazy. If you know the cause, you can figure out the treatment if there is one. Okay. Again, what's a great source of B12? Meat, animal tissue, absolutely. Okay, so pernicious anemia is caused by a B12 deficiency or a lack of intrinsic factor. Okay, intrinsic factor, I'll write it down at the bottom here. Intrinsic factor, this is a special enzyme in the GI that allows B12 absorption. Intrinsic factor is an enzyme in your gut, in your GI, that actually allows you to absorb B12 from your diet. Okay, so let's assume that I am missing intrinsic factor. I start throwing down Red Bull and steak. It's a lot of B12, but can I absorb it? So in this case, if I am missing intrinsic factor, can I supplement with B12? Would that fix my problem? Okay, so pernicious anemia, lack of B12. Either A, it's not in your diet, or B, you're missing the enzyme to absorb it. Okay. So, yeah, talking about pernicious anemia, you have your typical symptoms, but you also have possible neurological manifestations. So that means you can have pallor, dyspnea, weakness, fatigue, but this will affect your nerves. In fact, this causes nerve demyelination at the PNS. Why? Because you need B12 to make myelin. You need B12 to make myelin. So this person here, pallor, fatigue, dyspnea, weakness, and they can't feel their fingertips, or it's pins and needles in their toes. All because they're not getting enough B12. Does that kind of make sense? That's what I mean by a signature symptom. Somebody, you look at somebody's blood, it's too large, and they complain of numbness in their extremities, you instantly know it's pernicious anemia, because that's only associated with pernicious anemia. Okay. So we were talking about treatments there. Hey, if they're lacking B12, let's just give them B12. There's vitamins for that. Okay. But what if I'm missing the intrinsic factor? If I'm missing the intrinsic factor and I take a bunch of B12, I can't absorb it. How do I get around that? Injection. That's parenteral. Whenever you see parenteral, that just means not oral. If I can't absorb it through my gut, I inject it into my muscle, because that means it's already in my bloodstream. I don't need to absorb it. Okay. So athletes you might have heard of like B12 injections. Okay. Fun fact: B12 does not give you energy. It helps you access your stores of glycogen and fat to burn for energy, but it's not energy. Just a popular misconception. Okay. So either injection or oral B12. Folate deficiency anemia. 3 guesses on what causes that. Okay, it's not too bad, I promise. Okay. How do we treat folate deficiency anemia? The nice thing is there's no enzyme. There's no enzyme needed for folate, so you can just straight up give it oral. Okay. Here's a Red Bull, be on your way. In terms of symptoms, Similar symptoms to pernicious anemia, except there are no neurological symptoms. What this point is trying to get at, it's only the typical symptoms. Pallor, dyspnea, fatigue, weakness. So therefore, does folate deficiency have any signature symptoms? No. Okay, so that's why I'm saying some of these, none. Is a viable answer.
This might be a hard question.
Oh,
Is folate different from folic acid?
same thing, it just depends on which side of the pond you're in. UK, Europe, they like to say folic acid. Here in the US, we like to say folate. Both of them are B9,
Okay.
if you want some more confusion in that.
No.
Yeah, so it's just depends on however you want to say it. Like, it's like GI tract or GI tract with a T.
Okay.
Just
Because in
depends.
pregnancy, can't find the folate content.
Absolutely. So you'll get into that with peds and OB, but B12 and folate are added to grains to prevent neurotube defects, i.e. the tube that your brain sits in. One detriment could be something called anencephaly, where the baby's brain is outside of its skull because the skull never fully formed. So just tying this in, you don't need to write this down. You need B12 to make myelin, your brain. That's why.
Because my fiance's sister has fine. For that.
Mhm. Absolutely. So spina bifida is a little, it's not as extreme as anencephaly. All right. So second category here, microhypoanemias. Okay. So hey, guess what? They're small, microcytic, and they have less hemoglobin, but you already knew that. So starting off with iron deficiency anemia, this is by far the most common anemia worldwide. By far the most common. Okay, you have your typical symptoms in addition to spoon-shaped nails and glossitis. So these two right here are your signature symptoms. Straightforward on this one. How do you treat it? Yeah, either animal tissue or iron supplements. FYI, if you have iron deficiency anemia or anything like that, animal tissue is best. Taking in already fully formed blood and converting it into your blood is a lot easier than trying to convert it from a pill.
I get infusions for that.
You get iron infusions?
Yeah, and I also take the supplement.
Oh,
But it's very low.
very low.
Yeah.
So is it, do they call it iron deficiency anemia or is it something else?
No, that's what they call it.
Okay. Because we're gonna go through something else where I'm like, kind of sounds like maybe what's going on. Out of curiosity, with the iron injections, do they make you really fatigued or is it painful?
No, it helps with the fatigue a lot.
Oh, interesting. Okay. I remember somebody telling me that like whenever they got their treatments, like they get white for 12 hours, but then they spring back.
That happens, so it runs in my family, so it happens to like a relative, but for me, it's the opposite, like I'm energized.
That's awesome.
Yeah.
Okay. So spoon-shaped nails and an inflamed tongue. Okay, how do you know that this tongue is inflamed? You can't see textures. All you see is that it's puffed out. Okay, so that's a little bit of health assessment for you. All right, you guys ever see like iron in grains, like Special K? How do they get the iron in there? So this is a fun little science experiment you can do if you have little ones. Get some Special K, get some iron infused cereal, put it into a gallon bag, put water in there, let it sit for like half an hour, mix it around, swirl it, looks grody, stick a magnet on top. Guess what comes out of the cereal?
Iron.
Straight up iron granules, iron shavings.
Oh. There were a bunch of moms on Facebook that were like, look what they're putting in our kids' food.
First off, it's such a tiny amount. Second, this is not meant to be scary. This is for you to appreciate your body. Think about this. You can take in wrought iron, break it down to the anatomic level, and stick 1.6 billion atoms on a single red blood cell. That's what you guys do every day without even realizing. So, yeah, Facebook has its thing. You can flip the coin and just say like, holy shit, you're amazing. Yeah. All right, next type of microhypoanemia, sideroblastic. So with sideroblastic, it's an issue with the mitochondria. So basically it's caused by bad mitochondria. Okay. The reason is because your mitochondria makes hemoglobin and energy, yes, power plant. So this is supposed to be a joke written by the other patho guy. My English better. Poor mitochondria, less hemoglobin. Makes sense? That's why you're hypochromic. Okay. This is a genetic condition. If it's a genetic condition, is there a pill or something that treatment-wise? So here, no treatment. Okay, no treatment. If it gets really bad, if any anemia gets really bad, what's the emergency treatment? Blood transfusion. Okay, so technically a blood transfusion would work for all of these if it got really bad. But there's no long-term treatment for this. Okay. One of the let me see, signature symptoms here is ringed sideroblasts. Okay. Basically, you look at these developing red blood cells and you actually see black rings inside of these cells. It's weird. Those black rings are iron granules that haven't been synthesized to hemoglobin. So again, you look at this red blood cell, you're going to see little black rings in there because that cell is taking in iron, but its mitochondria is defective. It's not turning that iron into hemoglobin. So think about like if it was your job to, I don't know, fix cars, right? You fix a car, you send it out. You fix a car, you send it out. All of a sudden you can't. What piles up in your front yard? All those cars. Does that kind of make sense? All right. The next one here, the last one of the microhypos, thalassemia. Thalassemia is, again, a genetic disorder. Okay. Genetic disorders, how do we get them? From our parents. That's like albinism. It's autosomal recessive. That means you got one gene from mom, one gene from dad. Okay. The issue with thalassemia, genetic disorder, you basically just produce poor hemoglobin. Poor hemoglobin. Okay. So therefore, you have less functional hemoglobin, less red blood cells, etc. If you're curious, it's people of Italian and Greek descent, I believe, that are most at risk. Okay, you don't need to write that down. Okay. So thalassemia, just a genetic condition, you produce poor hemoglobin. There's not really a treatment for it. All right, so that was macro normal, micro hypo, not too bad. Now we get to normal. What size are my cells with normocytic? What about my hemoglobin? Wait, my cells, I have normal number cells and normal size and normal color. What could be wrong? Okay. The thing that these have in common, the normos, your red blood cells are fine. The problem is you don't have enough. Okay, your red blood cells are fine. It's just you don't have enough. So that's what these 5 have in common. Okay. So starting off with aplastic anemia. Aplastic anemia is basically bad bone marrow. Bad bone marrow. I.e., you just don't, your bone marrow doesn't produce a lot of these pluripotent stem cells. So I'm going to say decreased stem cells. Okay. Two types of aplastic anemia. Pancytopenia. Oh boy, do I like one. Pancytopenia. Penia, lacking, cyto, cells. What does pan mean? Like a pantheon. Yeah, everything. So pancytopenia translates to all cells lacking. All cells lacking. What cells would I be lacking with pancytopenia? Like what?
Or like blood cell. Like,
All of your blood cells come from your bone marrow. So it'd be all of your red blood cells, all of your white blood cells, all of your platelets. Okay, wrap your heads around this. If you have defective bone marrow and you're lacking red blood cells, what's the problem there? No oxygen transport. You're lacking white blood cells. You're immunodeficient, decreased platelets. I can't breathe, I can't fight infection, and I can't stop breathing.
great, that's terrifying. I've never been.
Pancytopenia, i.e. bad bone marrow. Okay, something's wrong with the bone marrow is not making these stem cells. This would be a great candidate, for example, for a bone marrow transplant. Okay, but by far, would you agree this is probably the worst thing that could happen?
And it's all genetic as well.
Sometimes. We do get back to that.
Would somebody who has that need like repeated bone marrow transplants or just like one of them?
Depends on how aggressive we can be about wiping out their whole bone marrow. We're going to use radiation to wipe out your bone marrow, and if we can wipe out enough and then replant in brand new bone marrow, you should be fine. Problem is, if we don't wipe out everything, then you're going to start having that interaction going on between my immune system and the person's immune system. In terms of is this genetic or not, generally we'll just keep it simple and say that this is genetic. Okay, this isn't something that you just get from somebody's sneeze. Thankfully, right? So aplastic anemia, bad bone marrow, we'll say again is genetic. Treatment for that, bone marrow transplant. Okay. Now, pure red cell aplasia, this is when we are just, the only thing that we're lacking is red blood cells. So let's think about this. If I am lacking red blood cells, but I got sufficient white blood cells, sufficient platelets, we know it's a bone marrow issue, so what part of the puzzle am I missing? Pure red cell aplasia due to a lack of EPO. Due to a lack of EPO. I'm missing this hormone. Why would I have less EPO?
Kidneys.
They come from your kidneys.
So if you didn't have a kidney.
Maybe I'm missing a kidney. Maybe I donated my kidney. I heard someone say kidney disease as well. Absolutely. If I'm missing a kidney, hey, guess what? I can't make as many red blood cells. Okay. So that's aplastic anemia. Treatment there, just give them EPO. Pretty straightforward, yeah?
Okay, I'm sorry, I lost the question. Is it like pill form?
It's an injection. Yeah, it's an injection. Great question. All right, next one. Post hemorrhagic anemia. Post means after. Hemo, blood. Rhagic, leaking. So after you bleed out, how much blood do you have? That's all this is. Okay, don't overthink it. I.e., after you finish bleeding, how much blood do you have? Less. So acute blood loss. What do you think treatment for acute blood loss would be? Give blood. Exactly. Keep it simple. Okay. Give blood. I'm going to say and fluids. Okay.
So for the symptoms for like Hemopatho, this type symptoms, one is it just like typical symptoms?
For the pure red cell aplasia, typical. For the post-hemorrhagic, typical. So this one is a little different because now you're immunosuppressed or deficient and you can't stop bleeding. All right. Hemolytic anemia. Patient presents with hemolytic anemia. What's wrong? Blood. Lytic means cut. Blood cutting / breakdown. Okay, what do you guys think is going on? Blood breaking down. The issue here is you have accelerated destruction of the red blood cells, i.e., you destroy red blood cells faster than you can make. You destroy red blood cells faster than you can make new ones. Okay. So it kind of makes sense that you would have anemia, yeah? What organ is responsible for breaking down old defective red blood cells? So if it's accelerated destruction, I have an overactive spleen. Again, my spleen is breaking down too many red blood cells. Okay. Let's kind of walk down this path here. If you have an overactive spleen, that means you're going to have increased red blood cell breakdown. What is a byproduct of red blood cell breakdown? Bilirubin. Too much bilirubin leads to what condition? In this pathway, do you see anything about the liver? Again, please don't just say jaundice is liver failure. It can be because of an overactive spleen. So, what would treatment be? Remove what? Can we do that? Can we just rip out somebody's spleen?
If you believe hard enough, but
If I take out somebody's spleen, why would they continue to live?
because it regrows.
Not the spleen.
The liver takes over. Yeah.
Treatment, removal of spleen. You can take out the spleen because the liver will compensate. Nice. So yeah, you can totally rip out somebody's spleen and sell it in Vegas. My whole goal is to make you guys paranoid, just like a little paranoid. Like I think paranoia is healthy for any profession. Too much paranoia is crippling, but just a little bit of why. Because guess what? You're going to have the child where the parents can ask, well, why? Why? Okay, so fourth anemia, sickle cell anemia. We're going to talk a little bit more about it. It is autosomal recessive, which means, how did I get this? One from mom, one from dad. I got from both parents. Okay. What ends up happening is your red blood cell sickles or it collapses in on itself. What's kind of interesting is, let me say the triggers. Okay, if somebody has sickle cell anemia, their red blood cell looks like yours or mine, fuzzy red donuts, most of the time. However, during times of hypoxia, inflammation, or stress, that's what causes your red blood cell to sickle, i.e. it goes from being a nice circular little red blood cell and collapsing in on itself. So, assuming that this sickle cell patient never encounters stress, never encounters hypoxia, never encounters inflammation, would they know they had sickle cell? Is that a realistic life though?
No.
So they'll usually find out sooner rather than later. We're going to talk more about sickle cell anemia here on the next slide. So this is just introducing. Okay. Last one, anemia of chronic inflammation. This one's probably one of the more general ones. You don't need to write these down. I just want you guys to see this pattern. AIDS, lupus, renal failure, malignant cancers. Are these disorders that you can just get over in a weekend?
No.
These are pretty serious, life-threatening disorders, yes? In anemia of chronic inflammation, the issue here is your body has a choice. Body has to choose. Fight the disease or make new blood. There's only enough resources for one. In anemia of chronic inflammation, your body chooses, do I fight AIDS? Do I fight this cancer? Or do I make red blood cells? Which decision does your body make? That's why you have anemia. Okay, so for treatment for this, there's not really a treatment because it depends on the disease, right? Signature symptoms, it depends on the disease. That's why I'm saying for this one, probably don't worry too much about it. Okay, it's just you have some sort of really life-threatening disease and there's not enough resources to actually make blood.
Was there a treatment for sickle cell?
We're gonna get to it. Great question. So talking about sickle cell anemia, this is your collapsed red blood cell. Okay, so what does that mean for oxygen carrying capacity?
Not great.
Not great, it tanks. Generally, this is actually pretty bad, but there are two instances where there's two protections this affords from malaria. Sickle cell anemia actually protects people in two different ways from malaria. You may have heard of malaria, yes?
Yes.
What is it? Is it bacteria, virus, parasite? It's a parasite. It's a parasite that lives in your red blood cells. Why are your red blood cells the perfect hiding ground? My body doesn't attack them. My body doesn't even check my red blood cells because my red blood cells are missing something. They don't have a nucleus. So my helper T cells, my macrophages, they don't even check my red blood cells because there's nothing to check. Perfect hiding spot. What's interesting is with sickle cell anemia and your red blood cell collapses like this, a collapsed red blood cell will leak potassium. This in turn starves the parasite. When you collapse, you're going to leak this potassium because remember, potassium should be inside your cell. This parasite needs potassium to survive. Cool. Secondly, your body understands that this is not normal. This is not helpful. This is a defective red blood cell. What do we do with defective red blood cells? Kill them by sending them where? We accelerate movement of the collapsed red blood cell to the spleen for destruction. So this parasite crawls inside of your red blood cell, it collapses. It's going to starve and immediately go to the spleen and get destroyed. This sounds awesome. In fact, the reason why I think this is so fascinating, this is evidence that human evolution is still going on. in places of high malaria, we see high levels of sickle cell anemia. Now, is this the next step for us in human evolution? Maybe, not quite. So here's just showing your red blood cell. This is that parasite that lives inside of your red blood cell. Okay, so if you have sickle cell anemia, great. If you live in areas with high malaria, does that apply to most people? All right, take a look at this here. If your red blood cells sickle, there are these little sickles, these little curves, these little crescents, little croissants. What happens to the ability to flow through a capillary? They get stuck, it becomes decreased. So this creates almost like a blood clot. But is there a clot? Is there fiber? Platelets? They have a clot here. And if I give them clot busters, is that going to do anything? See the problem here? So what I'm trying to get at, we lose reversible deformity. This puts you at risk. So I'm going to say lose reversible deformity, increase risk for an ischemic event. So this happens in your brain. What could that cause? Stroke. This happens in your heart. Myocardial infarction, heart attack. So out of all of these anemias, yes, you're missing blood, but this is what's going to set you up for a full-on event. You don't get a stroke from iron deficiency anemia. You don't get a myocardial infarction from thalassemia, but you can from sickle cell. So going to the treatments now. What caused my sickle cells to collapse in the first place? Wow.
Yes, that's for.
So what do we do in terms of hypoxia? How do we treat hypoxia? We can give them oxygen. That will prevent further cells from collapsing. What about inflammation? How do we treat inflammation? I was going to say just anti-inflammatories. Stress, I got nothing for you. Sorry. You let me know when you guys figure it out. Okay. And those are the three categories of the anemias. Again, just keep it simple: causes, signature symptoms, and if there's any possible treatments. Sound good? All right. So we're going to take a break, but now we're going to get into the other stuff. So that was lacking red blood cells. We're going to talk about too many red blood cells, and then lacking red blood cells, too many white blood cells, platelets. Those as well. We have 10 minutes, so 10:45. We'll pick. Oh wait, class ends. Oh yeah, 10:45. We're good. Keep thinking that class ends at 11. I'm like, well. So yeah, 10:45. We'll pick back up again. EPO is a hormone. Erythropoietin.
Is that medicine? It's not made in the liver.
That was made in the kidneys. So EPO, erythropoietin, is a hormone that comes from your kidneys. Yeah.
Thank you. Damn, you said.
So, EPO is erythropoietin, which is a hormone from the kidneys, and it's released during hypoxia versus TPO, thrombopoietin. And how you can tell erythro deals with your red blood cells. So
Okay.
poietin is hormone for your red cells. Hormone for your platelets.
Okay.
It's a hormone from the liver. It'll be during hemophys, like when we first talked about it. So, you spent 10 years of like research, like bachelor on different labs, or just?
Yeah, I was a research assistant. Started when I was a work study. Started my first year doing public health. And then was in a pediatric hematology oncology lab for a while. Then did lung cancer for about 3 years.
So I was supposed to say, like, this is all stuff you've seen before.
A little bit, yeah. Some of it is stuff that I continue to like learn more about, depending on what I was doing.
Mhm. Yeah, that's kind of what how I ended up in research too, was I was just looking for income.
Yeah, that's it.
So I jumped in the first research lab I jumped into was a physiological aging lab where we looked at basically like oxidation and things like that. We one of the cool studies is we looked at boa constrictors. So boa constrictors, they only eat once every month, every 4 weeks, right? But when they eat, they grow down. So when this boa constrictor eats something, its heart grows 4 times its size. Now that's not edema, that's not swelling, they grow 4 times the number of cells. We found that if you take the fatty acids out of the pericardial sac from a fed boa constrictor and inject it into a mouse, you can make the mouse's heart grow 4 times its size. So ultimate application here. Do you want the heart of Lance Armstrong? Give it to you. What we investigated was, can your arteries and your blood vessels handle that pressure without tearing? It didn't look so good. So we know that. So I did that for a while. What else did I do? I did biomechanics research. We looked at parkour and longboarding. I was the first person to categorize and characterize the forces of longboarding. So I used to longboard quite a bit too. So that was fun. We used my advisor. He made a treadmill that can actually detect forces in 3 dimensions. So it was meant for skiing. We're like, easy, Jack. That's before. Let's throw somebody on a skateboard on a treadmill. So we did that. Parkour was interesting. We looked at the vertical wall run, like how is it that people can run straight up with like gravity? Turns out you can't. Gravity always wins, but you can slow how fast you're losing to gravity. Yeah, and then from there, I did some more biomechanics, and then I went into my master's.
Do you plan on like working as a nurse when you graduate, or do you want to just continue teaching and have that base knowledge as well?
You know, I think my heart's still in teaching. I think I don't know if you guys have thought I kind of like teaching. But in terms of the nursing degree, the thing that I think I might want to get into is clinical trials, like working with patients that are going through these experiments, because I want to keep up with the research, I want to keep up with the science, but also like it's all about the future generation. Like I am not here to fudge data. You know, if this medication works, I want it to freaking work for this person, the next person, and so on and so forth. One of the big issues that recently came up was this Alzheimer's medication. I don't know if you guys heard.
Yeah.
Did they pull it?
No, I said it's bullshit.
Oh, it's complete bullshit. So this medication is, I think, 20 grand a year, 50 grand a year for treatment. And it's only going to stop the progression of Alzheimer's. It doesn't treat Alzheimer's. But the data looks terrible. They didn't test it on any humans. And it looks like they cherry picked out of the
Just rats, right? Rats and mice.
And it seems like what happened was they pushed, like basically lobbied or legally tried to the FDA board. 2 members ended up presiding over it, like presiding over it. We're not community partners. So it's one of the fastest prescribed medications and the most.
That's fine.
You can afford 50 grand a year. Like if I have 50 grand laying around and I forgot that I had 50 grand, sure. But like, that's nuts. It's a nice retirement home at 50 grand a year. Oh shit.
That's it.
Go down to Cuba.
I was like, that's a nice little condo on the beach in Hawaii, right? Out of sheer curiosity, if you go into clinical trial research, do you need nursing experience first?
As a nurse, no, because you're blinded in the study too. You don't know who's getting actual medication, who's getting placebo. Your goal as a nurse is to report symptoms and report any changes.
But they don't need you to have like 6 months on that sort of thing like that.
Depends on what the clinical trial's for. So like if it's for implants, probably. But if it's like pharmaceutical, you're just thinking about it. Like I'm old, y'all. I don't have the adrenaline, like I don't wanna do flight for life, okay, I don't get in the helicopter, I don't wanna do ER, like that's too high stakes for me, I want old people or something slow.
You don't wanna hop on chest every shift?
No, oh God, no. Like chest compression, like I felt somebody's rib crack, like, how good.
I never want to be the first one because I'm like, I'm sorry.
Yeah, like turning 83-year-old Ethel's chest cavity to soup. Not my idea of a good Tuesday. Yeah. You guys are young, you guys take that high adrenaline, I'll take care of the old people. People are where it's at. Like they can be the sweetest or the most racist. Like,
I just love, oh yeah, they just have no. They don't have any filters on, they don't, no, they don't, I'm like, I'm not. They're like, I'm too old. I appreciate the fact that you just said that, super not appropriate, still not gonna tell you that. You know better, it's like ranch Reno, for like all the time. I was teaching an infection here. He was wearing like a long sleeve shirt, so I was like, can you take like an arm out of your shirt or something? He's like, I don't really want to strip. Cause I don't want you to get too excited. And I was like, ugh. But thank you for being honest.
like some of them too, like their humor is funny. I'll pick on my dad. So my dad's having these yearly prostate exams. Every year they ask him like, so any requests for prostate exams? It's like, yeah, I want the nurse with the smallest fingers, please. So I'm just like, I don't know. I like old people because what you see is what you get. If they're angry, they're gonna let you know. If they're grumpy, you can see it, right? Like, yeah.
I love old people when you tell them so they soften up. Especially if you throw them like a little inappropriateness. They're like, okay. They're like, I can jive with you. They're great to play something. I'm like, put it somewhere. Stop talking. Is it talking back to you? What does it say? I need to know.
Okay, so selling on. We were talking about two issues of anemias, lacking red blood cells. We're going to flip that. We're going to talk about too many red blood cells, i.e. polycythemia. Poly means many. Many. Cyth refers to cells. Emia in the blood. So too many cells in the blood. In the clinical field, if you're talking about too many cells or too few cells in the blood, the clinical default, is red blood cells. Okay, unless they specify white blood cells or platelets, just default to red blood cells. Like anemia, lacking blood. They're usually lacking red blood cells. Okay. So polycythemia, overproduction of red blood cells, two different ways that this can happen. So first type of polycythemia is relative polycythemia, caused by dehydration, decrease in water. So if you are not getting enough water, does that make your blood thinner or thicker? Thicker. So it seems like you're making more cells, but the truth is you're just missing water. Okay, so you're going to see increases of hemoglobin hematocrit values. Treatment for this, what do you guys think? Usually IV fluids will be fastest here. You really want to see relative polycythemia, and this is an FYI, let me hold this up. Pediatrics, when kids go travel, especially to the tropics, anybody that's been to the tropics, you know the food there takes a little while to get used to. Poor kids, if they've been vomiting and diarrhea for 3-4 days, they're just lacking that much water. Okay. The other type of polycythemia is absolute polycythemia. Okay, this is in truth, they have too many cells because they make too many cells. There's kind of two subtypes, so 2A or 2B. Polycythemia vera. Anybody fan of Boondock Saints? Anybody see that film? One of the tattoos is Veritas. Vera means truth. Polycythemia vera, or the true polycythemia, i.e., your bone marrow is overactive. Your bone marrow is spitting out too many cells. So that would make your blood thicker, yes? Weird thing here. In med school, one of my friends, when he was talking about in residency, one way they diagnose this, they ask you, how do you feel after a hot shower? If the answer is itchy, you might have polycythemia vera. Don't become hypochondriacs. Like, just turn down the temperature of your shower. But I'm just saying that's one of the questions they ask. So either A, your bone marrow is overactive, or B, you have too much erythropoietin. Why would someone have too much EPO? Kind of. What's the trigger to release EPO? Low oxygen. What if I have chronic hypoxia, chain smoking, chronic bronchitis, emphysema? If I'm not getting oxygen, that would cause my kidneys to be overactive, more EPO, more red blood cells. We'll talk about the second one here, but when you start getting tumors on endocrine organs, that increases hormone output. Right now, just chronic hypoxia is what you need to focus on. So, what do you guys think treatment would be if I have overactive bone marrow or producing way too much EPO? I wish there was one. So what? Give oxygen maybe, but then I would be walking around with oxygen for the rest of my life. It's kind of expensive, yeah. So think about it. What's the issue here? What's wrong with our blood? Too thick. So if you have too many cells, how can I get rid of cells in my blood? Yes, the treatment is actually bloodletting. So guess what? Bloodletting is back, y'all. Yeah, except nowadays we call it therapeutic phlebotomy. Therapeutic phlebotomy. So the problem is you make too many red blood cells, yeah? Why don't you donate them? I'm just saying you just donate, regardless if they can use it or not, you just donate his blood. So this person is going to go and donate blood once a week versus the average person once every 8 weeks. You're thinking about like the silver, taking in too much silver?
Yeah.
There's a medication that causes you to express that blueness. Unless you're thinking about like cyanosis.
Oh, I know they discolor, I know they do.
My guess is that silver buildup, because I forgot what medication it is, but yeah, it can turn something blue. So therapeutic phlebotomy, i.e. bloodletting. Problem, you make too much blood, just get rid of it. Don't okay. All right, so now talking about white blood cells, leukocytosis. What's going on there? Cytosis, condition of cells, i.e. more white blood cells. And why do I typically make more white blood cells? Response to stressors, in this case, infection. Leukopenia, what's going on? Lacking white blood cells. So that's your, I'm just gonna say immunodeficient. Immunodeficient. Okay, it normally, again, average person, average life, it is not normal, not beneficial, not beneficial. When would it be beneficial? Organ transplants, autoimmune disorders, flare-ups, right? Treatment for leukopenia just kind of depends. Generally, it's going to be a bone marrow transplant. Okay. So I would say treatment. Usually bone marrow. All right, let's talk about some weird things that affect your immune system. Infectious mononucleosis, more commonly known as mono.
Can I ask another question? Sorry.
Yeah, about
About
Yeah.
So it says we want it to have a transplant, but then if you're reversing it, you have a bone marrow transplant, is there like big reactions?
that gets into a whole level that I'm not familiar with in terms of transplant criteria.
Okay.
So that is an interesting rabbit hole. I just don't know.
No worries.
Sorry. Infectious mononucleosis. You guys probably know it as mono. How does a person get mono?
It's kissing.
Salivary donation or transplant. Okay, whether it be kissing, beer pong, licking a spoon, or putting it back in the drawer for you to find out. Whatever. Okay, the weird thing about mono is it's a virus, typically a virus, that attacks specifically your B cells. It's a virus that attacks your B cells, kind of like HIV attacks your T helper cells. Mono goes after your B cells, both your memory and your plasma. Okay, most of the time it's caused by Epstein-Barr. Epstein-Barr virus is freaking weird. Epstein-Barr virus is freaking weird. We're going to leave it at that. Okay, but mono is a virus spread through saliva that attacks your B cells. Anybody ever have mono?
Surprisingly.
No?
Shouldn't say surprisingly.
It's grody much?
No, I said surprisingly no.
Oh, yeah, I'm
I've
actually.
just been around people who have had mono, so that's why I'm surprised.
Oh, gotcha.
Not that, like, I'm
I'm like your finger slut.
I was about to say, you're beer pong champ. You never need that washed up, right? I don't know where that popped up. I'm sorry. So most of the time when people get mono, sore throat, life sucks for about a week and a half, right? Then they get over it, they get back to it. Serious complications are infrequent. In some rare cases, your spleen can explode. You kiss some random dude or girl, and then your spleen explodes the next week. What? Why?
Because it gets more.
Why? Why does the spleen become enlarged?
Because it attacks the blood cells, so then they go to the spleen to get killed.
Your B cells, yeah, your B cells are infected. Where do infected or defective cells go to? So I'm gonna say infected slash defective blood cells.
Had mono, it got tackled, and I don't.
Go to spleen.
He like got up, went to the sidelines, collapsed. Friday night lights. Yeah.
So these infected defective cells, they go to the spleen to be destroyed. That's going to cause your spleen to enlarge. So if there's some sort of physical impact, car accident, football game, sorry, that spleen's going to rupture. Now, what's the problem about your spleen rupturing?
Holds a lot.
How much blood?
Or more.
15%. So we're gonna look at severe or significant blood loss very quickly. That's the issue with mono. Now, typically, does this happen? No. Again, very infrequent. Okay, but this is again trying to solidify the idea of defective or infected blood cells go to your spleen for destruction. Your spleen is just like your lymph node. It's going to get swollen if there's too many defective cells. Okay,
Will they feel it?
there's their spleen rupture.
No, the inflammation at first.
It'll feel tender. So you guys are learning about the abdomen, right? When you're palpating, that's why they say if you can ever palpate the spleen, what do?
Go to your.
You immediately notify the physician. If you can feel somebody's spleen, you immediately notify the physician. That's a test question. Straight up telling you like that's what I have. Okay. Don't poke people's spleen.
Yeah.
You shouldn't be able to. Okay. Right. Leukemia. So leukemia is basically cancer of the bone marrow. And this is what's kind of heartbreaking about leukemia. Cancer of the bone marrow. If your bone marrow gets cancer, what comes from your bone marrow? Everything. So you're going to be looking at cancerous red blood cells, cancerous white blood cells, cancerous platelets. Okay. There are different types of leukemia. I'm not going to get too crazy with it, I promise. It's sorted out by cell type. And then relative maturity. Okay. I'm going to explain this, but you don't need to take notes on it. This is if you're curious and if you're interested in leukemia or working with kids. If somebody has lymphocytic leukemia, it's cancerous lymphocytes. What are my lymphocytes? Two types of cells. B and T. Somebody has lymphocytic leukemia, they're releasing cancerous B and T cells. If they have myelogenous leukemia, it's anything else. Okay, again, you don't need to write this down. This is just me explaining how they categorize the different leukemias. Acute versus chronic. Acute, they're very immature cells, so they still look like they're pluripotent stem cells. Versus chronic, they look more like a finalized cell. Okay, again, you don't need to worry about it unless you're curious. These are the 4 different types of leukemias. Again, you don't need to translate it, but acute, so these look like pluripotent stem cells, lymphocytic, cancerous B and T cells. That's how you would go about that, if you're curious. What you need to know, all kids call adults. All kids call adults. Huh? Acute lymphocytic leukemia, all mainly affects kids, adolescents. Versus CLL, chronic lymphocytic leukemia, mainly affects adults. Okay, that's what you need to know. I.e., which leukemia affects mainly kids, which leukemia mainly affects adults. The other one that I want to point out here is CML. This is due to the Philadelphia chromosome. The Philadelphia chromosome.
What's that called?
I'm going to show you on the next slide, I promise. I promise. The Philadelphia chromosome. So if you really like Philly cheesesteaks, they're amazing. Especially if they use proper cheese whiz. Yeah, judge me. My cheese comes in a jar, but it's stable at room temperature. Judge me.
I know.
All right, cheese whiz. All right, here's your chromosome 9, here's your chromosome 22. This is what they normally look like, okay? In the Philadelphia chromosome, what ends up happening is we switch parts of 9 and 22. we end up with a, notice chromosome 9 gets longer. We end up with an elongated chromo 9 and a shortened 22 or a truncated, shortened chromo 22. So, i.e., chromosome 9 and 22, their little tail ends, they end up getting switched. This shortened chromosome becomes your Philadelphia chromosome. Okay, why do we care? 95% of people with this genetic condition, where we actually can see this, end up with leukemia. 95% of people with this genetic condition get cancer, i.e., if you look at some of these genes and they have this, what are they going to have? It's almost a guarantee, 95%.
So is that like a translocation?
Yes,
It is.
yes, it's a translocation.
Just of the 22 and 9.
Correct, correct. Okay, so CML, i.e. it's associated with the Philadelphia chromosome. If you see the Philadelphia chromosome, you're looking at leukemia. Good.
So the other 5% is just.
I don't know what the other 5% is. It could be that they don't get it. Or it could be noise, i.e. the data collection wasn't accurate enough, or they died before we could actually see if they have leukemia. Or 5% also like smoking on the side. I don't know. So lymphadenopathy, lymph referring to your lymphatics, straightforward. Adeno means gland. Adeno means gland. Pathy, disease. So, what are your lymph glands? What are the glands in your lymphatic systems called? Lymph nodes. So, lymphadenopathy is disease of the lymph nodes. Disease of the lymph nodes. Now, you've probably seen this before. Your enlarged lymph nodes, palpable and tender, yes? Last time you were sick, you could feel it, right? That is local lymphadenopathy. Why? Why would your lymph nodes get enlarged during times of sickness?
A lot
of the cells, a lot of the dead neutrophils, a lot of the infected cells are going to go to your lymph nodes to be destroyed, just like your spleen. Just like your spleen. You're going to the lymph nodes, your filter's getting clogged, that's why it gets bigger. Okay? Now, you guys have had swollen lymph nodes, yes? Did you survive? So would you consider that physio or patho? Physio. It should be an expected reaction, right? So it is typically physio. Because, hey, guess what? The swelling went down, life went on its way. However, if your lymph nodes don't stop swelling, if your lymph nodes are still swollen and palpable 2 months after, that's not weird. Something's wrong. Okay. That can lead to general lymphadenopathy. General lymphadenopathy, that means general all over my body. My submandibular, my axillary, my groin, all over my body. Now let's think about this. If your lymph nodes become swollen with infection and all of my lymph nodes are inflamed or swollen, what does that tell you about my infection? It's systemic. So what kind of diseases, what kind of infections would you see systemically? Sepsis and malignant cancers. Cancers that are spreading. Okay. So, I'm going to say, sorry, this is patho. General is patho. So you're going to look at this chap here. That's not facial hair, y'all. Those are his lymph nodes. Now, another way to look at it, look at the width of this gentleman's neck. It is almost as wide as his face. Okay. Swollen armpits, swollen groin. What does that tell you about his infection?
It's all over.
It's all over. It could be sepsis, it could be malignant cancer. Bad news bear. Okay. All right, next up, lymphomas. Lymphomas are defined as malignant lymphocytes. So cancerous being T cells. So you might be asking, what's the difference between leukemia and lymphomas? They're both cancerous cells. Leukemia, the cancer is inside the bone marrow. Lymphomas, your B and T cells leave the bone marrow, then get cancer. Okay, so they're both cancerous B and T cells. The question is, was it cancerous in the bone marrow, or was it outside of the bone marrow? So here, lymphomas, cancers being T cells outside of the bone. Okay. Two kinds of lymphomas I'm not going to go crazy in depth with, just superficial. You have Hodgkin's lymphoma, which is denoted by the presence of Reed-Sternberg cells, RS cells. Or you have not so Hodgkin's lymphoma. It's either Hodgkin's or not Hodgkin's. Hodgkin's was kind of selfish into two disorders. Okay. So talking about Hodgkin's lymphoma, these are your RS cells, your Reed-Sternberg cells. What's kind of weird about these cells?
Yeah.
Yep. Kind of looks like a face, right? I don't know. All right, yeah, exactly. They have two nuclei. That's pretty abnormal. Again, because this is lymphoma, these cells are dysplastic. What are these cells? Because it's lymphoma. Yep, dysplastic lymphocytes, i.e. B/T cells. Okay, these are dysplastic B and T cells. That is Hodgkin's. Not so Hodgkin's is mainly Burkitt's lymphoma. Okay, Burkitt's lymphoma typically happens in kids. Now we don't know what causes Burkitt's lymphoma. It seems to be associated with Epstein-Barr or HIV. So if a kid gets Epstein-Barr or HIV, they seem to be at a higher risk. But again, associated does not mean caused. We don't know what causes it. Okay. So non-Hodgkin's or Burkitt's lymphoma, kind of still a little bit hand wavy, happens in kids, and they get these excessive submandibular lymph nodes. Excessive. But again, you would not see the dysplastic B and T cells here. Okay, they don't have Reed-Sternberg cells. All right, so talking now finally about platelets. You do not need to know these ranges yet. You will in foundations though. Okay, for me, I'm just concerned with the term and then the complications. Thrombocytopenia. What's your big concern there as a nurse if your patient has thrombocytopenia? Why? Less platelets. Less platelets means no platelet plug, therefore no clot, no hemostasis. Very good. Thrombocythemia. What's your main concern as a nurse?
Yeah.
Excessive clotting, because that is your coagulable state. Okay. I don't really care about any of the subpoints. Just know the term and then what you would be concerned about. On the grand scheme of things, I would say both of these, for an average person living an average life, this is pathological.
Bottom's pathological, is that what you said?
Yeah, for both of them. For an average person living an average life, we do not want to be messing with platelets. All right, so talking about disorders of coagulation here. First up was von Willebrand factor. Anybody remember Sir von Willebrand?
Attract.
Von Willebrand factor, this is your homing signal. Homing signal for the platelets to plug. So if Sir von Willebrand is missing, i.e. we don't have Sir von Willebrand factor, would I form a platelet plug? My platelets don't know to go, they're not going to activate, so therefore would I stop bleeding? No. Vitamin K. So vitamin K, I believe, was discovered in Switzerland or Germany, I can't remember. But how they came up with vitamin K is because clotting in their language starts with a K, it's a hard C. So vitamin K is used for clotting. In fact, vitamin K is converted into prothrombin by the liver. Vitamin K is converted into prothrombin by the liver. So a couple of points here. First up, prothrombin. That was the first step of which cascade? Not intrinsic. Not intrinsic. They feed into it. Starts with a C. Prothrombin is the first step of which clotting cascade? Starts with a C. Both intrinsic and extrinsic feed into it. It's something they share in or common. Yes, classical or common cascade. So prothrombin is the first step of the common / classical cascade. In order to get prothrombin, you need vitamin K, which is again covered by your liver. When's the last time you guys have had a vitamin K supplement? Since you were born, but ever since now, since you were born until now, not really ever. Can you still clot your blood?
Yes.
Why? Because vitamin K is produced by your gut biota. The little bacteria living in your colon, they poop out vitamin K. We take that bacterial poop and we use it to clot our blood. That's why you've never had a vitamin K injection ever since you were born. However, babies, when babies are born, they are born 100% sterile. There is nothing in their gut. This is why babies get a vitamin K injection within 24 hours of being born. Just in case I accidentally dropped the baby doesn't bleed out. The baby can bruise. The baby can stop bleeding.
But it's not this gut
Biota, B-I-O-T-A. Sorry, gut biota, B-I-O-T-A. This is the bacteria that live in your colon. We're going to talk more about it.
But biota just means like.
Yeah, like a biome.
Okay.
So like we call it the gut biota, or you can also call it your skin biota. It's like the collection of bacteria that make home on your skin, in this case, in your gut. Okay. So the bacteria that live in your gut, in your colon, that make your poop, they also poop out vitamin K that helps you clot your blood. Kind of cool. Liver disease. Liver disease causes a broad range of hemostatic disorders. Why? There are 4 reasons that we've covered thus far that tells us my liver helps with clotting. What are the 4 things my liver does that helps with clotting? So, liver functions that we've covered thus far. We just talked about prothrombin. Vitamin K gets converted into prothrombin. Vitamin K gets converted into prothrombin at the liver. What else does your liver do to help clot your blood? 3 other functions that we've covered thus far. TPO is part of it. Make TPO. Clotting factors 12, 11, 9, 8, 10, 7 come from your liver makes clotting factors. Now, do you want to be clotted forever? What do you need to break up a clot? Plasmin, which comes from. So your liver does plasmin for fibrinolysis. You see what I'm talking about? Like, hey, the liver's kind of tricky. It is all throughout this lecture and last lecture. So if your liver starts going down, why can't you clot your blood? 4 reasons. You can't convert vitamin K into prothrombin. Why else can't you clot your blood? No TPO means no platelets. Why else can't you clot your blood? No clotting factors. And even if you do clot, does that clot go anywhere? Why? There's no plasma. There's no plasminogen. What I'm getting at here is, remember, your liver is the central linchpin to this entire unit. Okay, and there's not just one slide where it's all on listed for you. So to kind of give you guys a little bit of like foreshadowing when we start talking about liver disease, liver cirrhosis, patients with compromised livers, it's so bad, the fact that they can't clot, they will cry blood. It's not like whole blood, but it's like pink tears. Okay, liver cirrhosis is not a fun way to go. Okay. All right. This slide here is just superficial stuff. Hemophilia. Hemophilia A is a deficiency of clotting factor 8. Therefore, hemophilia A is a broken clotting cascade or blank clotting cascade. Hemophilia A is a broken blank clotting cascade. Yes. Hemophilia B, also a deficiency of clotting factor 9, intrinsic or extrinsic? Intrinsic, yep. Also known as the worst Christmas gift to give a child. I have no idea why it's called Christmas disease. It really kind of seems fucked up. Fun fact, you don't need to write this down. Hemophilia is proposed to be the oldest genetic condition.
Why?
Why?
It's from the royal family.
Part of it can be, that's one of the ways it manifests, absolutely. Doesn't matter who you are, where you come from, your language you speak, doesn't matter if you hail from a distant island that's not been touched by humanity for the last 10,000 years. Every single person is at risk for hemophilia. It is all a genetic disorder that is programmed into us. Some of us express it, some of us don't. The fact that we all share this disease, that means we all had a common ancestor. That's why it's the oldest disease. This is the disease that unites us despite geography or ethnicity. It's weird. So there's like probably like some sort of tadpole at some point in the primordial pool that had hemophilia and it got to spread its genes. All right, last one, disseminated intravascular coagulation. So breaking this down, disseminated. If you disseminate information, that means widespread. Widespread. Intravascular, what does that mean? Inside, vascular, inside the vessels, very good. So inside the vessels, coagulation, exactly as it sounds, you're making a clot. So what is happening here? Disseminated intravascular coagulation. You're getting clots all throughout the inside of your vessels, everywhere. Problem?
Yeah.
So Dick is highly fatal. Oh my God. Don't get Dick. Okay? Like, Dick is super, super bad because, hey, your whole body's turning into a clot. Now, the problem with Dick, okay, your clotting factors are limited. What happens when you run out of clotting factors? You turn into a giant bleeding clot. That is Dick in a shell. Okay, I'm really surprised you guys keep keeping like a straight face with this. So, heads up. It is actually pronounced DIC. DIC, because people who are professionals call it death is coming. I like to have a little fun. I'm going to call it Dick in my classroom. Okay? So if you call it Dick here, it's cool. Just a heads up when you go to clinicals, don't go like, oh, that patient got Dick. Okay, like, don't do that and blame me. I'll deny everything. I do have a challenge for you though. In MedSurg 2, this comes up. Your instructor for MedSurg 2 is named Professor William Borman. Upstanding gentleman. He was a cowboy raised in Texas, but he was raised with manners. Sweet guy. Your goal is to get him to call it Dick. I sent every single patho class to him, and none have actually got him to actually pronounce it as Dick. He always says, "Oh, DIC." Get him to call it Dick.
Challenge yourself. Come on.
So, how does one get Dick?
Failure.
I was gonna say Tinder, but I mean
I was gonna say,
Grinder. I don't know. But yes, multi-organ system failure because of sepsis. Okay, so just heads up, I know I'm joking about this. I think we all need a little bit of laugh. I think that's an exam question. Might be a quiz question, I'm not really sure. But hey, you get sepsis, it can lead to death. Okay. No, but in all seriousness, like this is actually pretty terrifying. Somebody with this, again, their whole body's turning into a clot. So if their whole body is clotted, can you give them fluids through the IV?
No.
If I give them a clot buster, will that make things better or worse? Why?
Bleed out.
They're
Because they're
already
already
bleeding out, and then you're gonna make them bleed out faster. Somebody gets to this point right here, there's no going back. That's why they say death is coming. So
So there's nothing.
like it is bad news bear, completely and thoroughly. People do come back from it, but it is a slow and a very extended stay in the ICU. Holy cow.
So like, what do you do?
Is my mom's right? Oh.
Prayer.
What?
Prayer.
It's literally like dying, or like dialysis, dying.
Yeah, my guess is like you gotta suck out all those blood clots and try to put it in new ones, but it's not pretty. Now, the issue or one of the lab values that you use to measure DIC or DIC, D dimers. So D dimers would be off the chart because hey, they're clotting and they're breaking up those clots everywhere. High D dimers indicates DIC.
What causes this?
For DIC, generally sepsis, so you have this infection that's spreading throughout your body, or massive trauma. We're talking about I stepped in front of a train and broke every bone in my body. That's going to cause everything to start clotting, and then everything's going to start bleeding out. So sepsis or massive trauma. Okay. Awesome. So that wraps up chemo. Tomorrow we will start GI Phys and do a little bit of GI Patho. I'll explain why, but just heads up, we're gonna do a little bit of GI Patho tomorrow in addition to this. Okay. All right. Hopefully I'll have everything unlocked and ready for you guys to view. Yeah. Enjoy the nice warm weather. Tell me what the outside feels like.
We'll get you a little bit of vitamin D before your next class.
I know. The problem is like I'm here. So like I just want to leave all my shit here, but like I paid for this myself.